Welcome to the second of two sketches talking about the causes of microcytic anemia. Previously, we sailed with micropolo and were introduced to the thalassemias, a group of hemoglobinopathies that involve the protein subunits. This time, however, we're focusing on the heme itself. And you know what the perfect setting is for a thoughtful discussion of iron deficiency anemia and anemia of chronic disease? Why, an enchanted forest full of pale Germans, of course. Snow White, originally and more awesomely called Sneewittchen, is the tale of a homicidal, narcissistic mother with an enchanted mirror who makes several failed attempts at murdering her codependent, developmentally delayed teenage daughter. The daughter luckily survives long enough to marry rich and never have any other problems. The fable was titled simply Tale 53 in Wilhelm and Jacob Grimm's two-volume collection written in 1812 called Children's and Household Tales. And tales there are aplenty in the tome of microcytic anemia. Remember that TALES is our acronym that incorporates the important causes of microcytic anemia: thalassemia, anemia of chronic disease, iron deficiency anemia, lead, and sideroblastic. Let me remind you of a few important features of microcytic anemia that we discussed in the previous sketch. Those tiny pale teacups depict microcytic and hypochromic RBCs, and that less than 80 teapot should remind you of a mean corpuscular volume of less than 80 femtoliters. And those target-shaped saucers? Target cells, of course. And finally, an abnormally low reticulocyte count, usually less than 3%, is symbolized by the tiny tea bag. Remember that a tea bag is basically immature tea, just like a reticulocyte is an immature red blood cell. Gotta let it steep. All right, back to our story. Iron deficiency anemia is the most common type of anemia in the world. And anemia is common, affecting about 1 in 10 people. Iron in the body is separated conceptually into functional iron and stored iron. Functional iron is the stuff that exists in hemoglobin and enzymes. This functional iron makes up 2/3 of total body iron. This iron is actually being used to do stuff. The remaining portion is stored iron, present as ferritin and hemosiderin within macrophages living in bone marrow. Before you're able to store it in the body, however, it comes from the diet. It's separated from food by gastric acid and absorbed into enterocytes of the duodenum. In this scene, the duodenum is represented by the dwarf den, the mine where the dwarves haul in iron deposits. We even made the mine look all villous and small intestine-y. Once absorbed by the enterocytes of the duodenum, the crucial step you need to keep in mind here is that this is where iron stops. Iron does not go directly to the blood, but is instead stored in duodenal enterocytes in the form of ferritin, represented by these tin storage buckets. Ferritin is a protein that binds to iron in the cytosol. Once bound, iron just kinda sits there until it's needed. And actually, if your body says, "Nope, got enough iron, thank you," then the iron stays locked inside the enterocyte until the bowel mucosa sheds, and all of that stored iron is lost in feces. On the other hand, if the body is actively trying to take up iron, some of the iron in the enterocyte is transported into the blood via a channel called ferroportin. This name gives it all away. It's a port for iron to pass through into the blood. Kinda like this iron transporter here, out of the mine. Once the iron has crossed the ferroportin channel, it's bound to transferrin in the plasma. See how this transferrin dwarf's garb is a sanguineous red color? Transferrin is the designated shuttle for iron through the bloodstream, right into RBC progenitors in the bone marrow. Think trans for serum transport. Iron that isn't needed by RBCs is stored in macrophages within the bone marrow, like a bony vault. Remember, at Sketchy, a macrophage is a macro cage. Once inside the macrophage, iron is stored and bound to ferritin, just like in the enterocytes. So we've added in a few more of those ferritin tin storage buckets. Remember the in part of ferritin as well, because ferritin is how iron is stored inside of cells. Now, so far, ferritin has been shown as a strictly intracellular storage protein. However, small amounts are, in fact, secreted into the serum, and we can actually measure this. Serum ferritin levels reflect the total amount of stored ferritin in the body, so it's used as a surrogate for measuring iron reserves. Remember, the serum ferritin level represents iron stores. When the body has enough iron, the liver senses it by grabbing a bunch of iron off of all of those saturated transferrin molecules that are floating around in the serum. Think of it this way. When there's lots of iron in the blood, there's also lots of iron in hepatocytes, prompting the liver to say, "Okay, that's enough, people. See how overloaded that liver satchel is with iron? This activates the release of hepcidin from the liver, a molecule that's released into the circulation that inhibits further iron absorption. We chose a lock to represent hepcidin because hepcidin locks iron inside cells. At the duodenum, it blocks the release of iron from enterocytes, and it does this by degrading ferroportin. See how hepcidin is locking up that ferroportin process? It does the same thing at macrophages, keeping iron locked inside the cell and out of circulation. So remember, when there's a lot of iron, there's also a lot of hepcidin, telling your body that it's had enough. Conversely, when there's low iron, as is the case in iron deficiency anemia, then there's a corresponding decrease in hepcidin, so that more iron is available for making heme and RBCs to combat the anemia. And speak of the devil, here comes our anemic princess now. Yep, the dwarves think she's dead, and lay down their iron tools as they memorialize their pasty friend. Worldwide, the most common reason for iron deficiency is a vegetarian diet low in iron. Most of the iron in our diet comes from meat, after all. In the US, where there's no shortage of good old red meat, chronic unchecked blood loss is the most common reason for iron deficiency. In fact, iron deficiency anemia is most common in women of reproductive age because of heavy menstrual bleeding, pregnancy, delivery, and lactation, which all deplete iron stores. Fun fact, women lose an average of 1 gram per day of iron through menses. It's not a lot, but it can add up, especially if you're not replacing that iron. And that's why we've made this sash look suspiciously like a small menstrual river of sorts. You know, Shark Week. The Red Scare? What? Were you expecting whistling and whimsical animated woodland creatures in this story? In older men and postmenopausal women, and by that I mean in patients who are not menstruating, some kind of occult bleeding should be suspected whenever iron deficiency anemia is discovered. The common causes vary with geography and patient age, but in the US, when you see iron deficiency anemia without a cause, think GI cancer, as depicted by these creepy colonic cancer crab bugs. The rate is variable, but the prevalence of colon cancer in elderly patients with iron deficiency anemia can be as high as 30%. It doesn't have to be cancer, however. Even benign hamartomatous polyps can cause chronic occult bleeding. Other causes of chronic occult bleeding include erosive gastritis and gastric ulcers, like in that stomach-shaped burial site. Oh shoot, this is getting serious. In developing countries, occult bleeding is often due to infection by gastrointestinal parasites, especially hookworms, such as ancylostoma and Necator, as well as whipworm, known as T. trichuria. This is more common in developing countries due to higher rates of parasite transmission, combined with already poor nutritional status. Less commonly, disorders that cause inflammation and atrophy of the gastric mucosa can also play a role. Atrophy of the stomach causes decreased acid production, which is no bueno, because you need an acidic environment to release iron from food. Think back to our GI block when we covered both H. pylori-related and autoimmune causes of chronic atrophic gastritis, represented here by that dopey Helicobacter helicopter hat, as well as a couple antibody sticks propping up that inflamed stomach cauldron. Damage to the small intestine can also throw a wrench in this whole iron-absorbing machine, because iron from the diet is absorbed in the duodenum and jejunum. Celiac disease, for example, which causes inflammation and damage to the small bowel, is strongly associated with iron deficiency. Yep, that's the prince. Just a tad late, it seems. And that seal crest on his chest? It's our celiac seal, of course. All right, now that we've covered a few common causes of iron deficiency, let's see what happens in the body when iron runs out. First of all, remember that you have all that iron stored as ferritin in the bone marrow. This has to get used up first. Only after this occurs do lab abnormalities start to show up. With no iron available in the bone marrow, heme synthesis is disrupted, as depicted by this dilapidated heme-themed minecart. Heme consists of a porphyrin ring combined with an iron atom. No heme means no hemoglobin, which involves adding protein subunits around the heme molecules. And no hemoglobin means no red blood cells. On peripheral smear, you first see a normocytic normochromic anemia, so normal-looking RBCs, just less of them. As iron deficiency progresses and more progenitor cells grow up without enough hemoglobin, then the peripheral smear will show hypochromic microcytic RBCs. Small and pale, in other words. Pale from the decreased hemoglobin that's being loaded onto each new red blood cell. All right, it's time to talk about labs. Now, one way to measure iron in your patient is to stick them with a needle, get some blood, and measure the amount of iron in it. Some is floating around, some is bound to transferrin. This is called serum iron. And when that comes back low, along with a low hemoglobin and hematocrit reading, which clues you into some kind of anemia, you might think, oh shoot, this guy has low iron and iron deficiency anemia. Not so fast. All you're measuring is the iron that's floating around in the blood. And what you really need to look at is total body iron stores. As I'll show you in a second, the amount of iron floating around in the blood is also low in anemia of chronic disease. So instead of blood iron, to diagnose iron deficiency anemia, we look at iron stores. Iron is stored intracellularly as ferritin, remember? Symbolized by those ferritin tin buckets. And in iron deficiency anemia, ferritin stores will be low, an empty bucket. When the body senses that there's not enough iron going around, it gets worried and starts pumping out transferrin in an attempt to get as much iron into the circulation as possible. In this scene, transferrin is symbolized by the rods used by the dwarves to transfer the iron buckets around the camp. See how they raise transferrin into the air as they carry Snow White to the burial site? In iron deficiency, transferrin is elevated. At the same time, transferrin saturation is decreased. All that transferrin in the circulation with no iron left to bind. And lastly, lots of empty transferrin in the blood corresponds to an increased total iron binding capacity, abbreviated TIBC. Think of iron binding capacity as a measurement of available transferrin for binding. And there's a lot. Symptoms of iron deficiency anemia are generally subtle or even non-existent. But in extreme cases, patients may present with the usual anemia stuff: fatigue, weakness, and skin pallor, much like Snow White here. The skin pallor commonly associated with anemia can be appreciated most easily in the conjunctiva lining the eyelid or the palmar creases, regions where capillaries underlie thin skin. When the hemoglobin concentration gets critically low, the body will increase cardiac output to compensate for the lower oxygen carrying capacity. Increasing cardiac output allows a small amount of hemoglobin to deliver oxygen molecules more frequently and keep up with the metabolic demands of cells. We call this increase in cardiac output a hyperdynamic state, and it's associated with tachycardia and heart palpitations, depicted here by this dwarf trembling in grief. Let's take a moment to talk about the unique findings in iron deficiency, things you might see alongside anemia. Many of these complications are bizarre, poorly understood, and therefore definitely test question material. Remember Plummer-Vinson syndrome from our backstage esophageal sketch? It's represented here by these falling iron plumbing tools. This condition is composed of a triad: dysphagia, iron deficiency, and esophageal webs. While we don't exactly know what causes the iron deficiency, iron supplementation has been shown to help reverse the symptoms. The more classic findings in iron deficiency are a smooth red tongue, also known as atrophic glossitis, hence the smooth lip gloss, in addition to angular cheilitis, which consists of inflamed corners of the mouth. Hey there, Seal Prince. Looks like she's ready for that magic kiss. A lot of question stems will describe concave or spoon-shaped nails that are thin and brittle. This is called koilonychia and is symbolized by these coils popping out of her concave, thin, brittle mattress. The mechanism behind spoon nails is poorly understood, but it's thought to be due to poor blood flow to the nail beds. Now, an interesting aside. The term pica in medicine is used to describe a developmentally inappropriate drive to eat non-nutritious, non-food substances. The word pica comes from the Latin pica pica, which happens to be the name and genus for the magpie. Magpies are a part of the crow family, notoriously intelligent, and known for eating nearly anything they can get their beaks into. Pica is a DSM-5 psychiatric diagnosis. But when pica is for ice and ice only, it's called pagophagia. Unlike other forms of pica, pagophagia is not a psychiatric disorder, but a fairly specific symptom of iron deficiency. It's pretty rare, though, and definitely doesn't happen in most cases of iron deficiency, so don't expect all your patients to be chugging ices in the office. Treatment of iron deficiency anemia is easy enough. Lots of iron replacement. If anemia is mild, increasing dietary supplementation of iron with ferrous sulfate is all that's really needed. Of course, if diet isn't the only reason for iron deficiency in the patient, the underlying cause, such as GI bleeding or malignancy, also needs to be reversed in order to fully treat the condition. After iron deficiency, anemia of chronic disease is the anemia you'll see most often in your patients. It's also the most common form of anemia you'll see in hospitalized patients. Not only that, you may also encounter this type of anemia while traipsing through a creepy German fairy tale for... Oh my God. It's just a chronically diseased old hag. She even has a recurring symbol for chronic, that timeless and chronically aged grandfather clock. Like iron deficiency anemia, anemia of chronic disease happens because, yet again, iron isn't available for making heme. This time, however, it isn't because of inadequate dietary intake or chronic bleeding. Anemia of chronic disease, aka anemia of chronic inflammation, occurs when an underlying condition leads to an excess of inflammatory cytokines that inhibit the release of iron. All that inflammation is embodied by the inflammatory and unabashedly cliché witch cauldron. As this chronically inflamed hag pays for that hepcidin key with a few of our recurring cytocoins. Imagine cytokines, especially IL-6, causing hepcidin to be released from hepatocytes. Remember our friend hepcidin, the hormone responsible for iron absorption and storage? It's actually an acute phase reactant, and it even has antimicrobial properties. So it makes sense that the body releases it in inflammatory reactions. Once cytokines have brought on the hepcidin, it functions to shut down the iron absorption and trap stored iron in the bone marrow. Say it with me. Hepcidin locks iron inside of cells. In summation, inflammation leads to cytokine release, which increases hepcidin, which prevents iron from getting into circulation and being used. The net result is a classically normocytic, or often microcytic anemia, as not enough iron is available to make heme for the RBCs. Lab findings seen in anemia of chronic disease reflect a body that thinks it has a lot of iron in circulation, but actually doesn't. Let me show you what I mean. Iron stores in the marrow will be high. Remember that hepcidin is locking all that iron in its storage form inside macrophages. This is measured as increased serum ferritin, represented by a few more of those storage tin buckets inside the macrocage. This whole process involves driving iron out of the circulation, so serum iron is low. Hence the scattered iron tools on the forest floor as the other dwarf guy realizes that one of their own is in cahoots with the evil anemic woods lady. Transferrin is low as well, and that's why we've made that transferrin rod, usually responsible for transferring iron throughout the circulation, tumbling toward the ground. Low transferrin means a low total iron binding capacity, the classic differentiating factor between iron deficiency anemia and anemia of chronic disease. In iron deficiency, the body upregulates transferrin in the hopes of moving some iron around, leading to a high capacity to bind iron. In anemia of chronic disease, however, the body's being stingy with the iron, keeping it locked away. Downregulation of transferrin leads to a low capacity to bind iron, regardless of what the serum iron may be. Remember when I say binding capacity, just think of whether or not iron has the opportunity to bind lots of transferrin. Since transferrin is low, not so much. The resulting anemia is mild, and treatment is resolution of the underlying condition causing inflammation, or supplementation of erythropoietin in extreme cases. Just like in iron deficiency anemia, both the MCV and peripheral smear will show a normocytic anemia at first, with progression to a microcytic anemia as inflammation continues. Oh geez. I'm really bad with confrontation. Sure. I guess I'll buy some. I'll take the more steamy batch, I guess. Anemia of chronic disease is most commonly caused by chronic inflammatory conditions, including rheumatoid arthritis and inflammatory bowel disease. But don't think this is just any old anemia. Anemia of chronic disease holds a lot of records. It's the most common form of anemia seen in malignancy, and the most common cause of anemia seen in alcoholism. Want to know a secret? Promise not to tell? Well, this is why those blood cells are looking so unwell. Iron deficiency anemia is the most common cause of anemia in the world and results in a microcytic hypochromic anemia. Patients tend to have fatigue, pallor, and weakness, kind of like an undead princess, but may also have more interesting findings, such as Plummer-Vinson triad, which is composed of iron deficiency anemia, esophageal webs, and dysphagia, pica, angular cheilitis and glossitis, and even spoon nails. Why the pale face? Well, patients with a vegetarian diet, heavy menstruation, or occult bleeding from peptic ulcer disease, atrophic gastritis, intestinal polyps, occult colon cancer, celiac disease, or the occasional hookworm may be losing more iron than they take in. And remember, iron is absorbed in the duodenum. Locked away is cytosolic ferritin, ferroported into the blood, and carried around on transferrin, or locked away in macrophages as, you guessed it, ferritin. When the body's had its fill of iron, the liver makes hepcidin, which shuts down iron ferroportins from the GI tract and locks down those macrophages. The classic lab findings in iron deficiency anemia are low serum iron, high transferrin, high total iron binding capacity, and low ferritin. Sometimes, especially in the setting of inflammation, the body tries to lock iron away from the baddies within the body. Anemia of chronic disease, or chronic inflammation, is caused by the upregulation of hepcidin and downregulation of transferrin in an attempt to lower serum iron. This leads to microcytic or normocytic anemia and the classic lab findings of low serum iron, high ferritin, low transferrin, and low total iron binding capacity. And with that, I'm pretty sure you guys should hi-ho it on inside. Those clouds rolling in look awfully dark.